Uh, okay, good afternoon. My name's James Danger, and today I'd like to make a video for my third aid channel on mosaic embryos. This is the second in the series. Actually, the first one on mosaic embryos, the first one was on euploid embryos, as I'll talk about in a minute. The question here is, are mosaic embryos to be considered euploid or are they aneuploid? And I'd like to discuss 6 papers in this short talk. Well, none of my talks are ever short. They're always going for about 15, 20 minutes, but I talk as fast as I can. The first is one by Anthony Capello looking at this is the hallmark paper looking at the live births of the transfer of mosaic human embryos and basically showing that they're fairly healthy. A short one on counselling, which is not an open access, so I have very little information on it. But there are 2 important papers, one looking at the inherent bias in diagnosing mosaicism, and the second one is actually whether it's actually of any value clinically in having embryos described as being mosaic. I'd like to have 2 quick paper discussions at the end. One is looking at the capacity of embryos to correct themselves, and the last one is a short one from China, demonstrating that almost all embryos have some sort of mosaicism in it. So we've got our knickers in and not over nothing. So the talk that I had before, so this is a euploid embryo series. It's not about mosaic embryos. So this is really number 1. This paper looked at all the data comparing mosaic and euploid embryo transfers and surmised that as long as we're talking about low-level mosaic, low or medium-level mosaics, that basically the birth rates, abnormality rates, and miscarriage rates are all identical. So it's increasingly apparent that the pregnancy rate and health of children, at least today it's only a couple of years old, so maybe we have a bit more to go yet, are similar following the transfer of euploid and low-level mosaic embryos. But this isn't quite the same as high-level mosaic embryos, but as I'll show in a slide later on, there's actually far more low-level mosaics than high-level mosaics. So there's 2 views. On one side of the PGT-A, the genetic testing of embryos debate, are the numerous reports and reviews suggesting that the cumulative live birth rate between PGA cycles and non-PGA standard IVF cycles are basically the same. That is, you're not getting any more babies by testing the embryos if they're normal or not. So why do it? After all the untested embryos that have been transferred since 1978, and I know I've transferred thousands of them, had thousands of babies, we know that the children are the same as non-IVF children, that is the born after intercourse. On the PGT-A side of the debate, the data does show that by excluding the aneuploid embryos, the aneuploid are ones that have the wrong number of chromosomes. There are fewer miscarriages, about 50% down from 25 to about 12%, and fewer transfers are required to reach a live birth. But when you put all the embryos back, you're still putting back the healthy euploids, either the first or second or third transfer. So the babies either come with the first transfer, but you still have the same number of babies, but without the testing. So the fact that you have fewer miscarriages, which I think is a really important factor, that is one we don't talk about enough. This is good. It's expensive, but it's good. But it has also identified about 20% or so of embryos that are mosaic. That is, they're not normal and they're not abnormal. They're halfway between. And there's an increasing debate about whether to treat these as normal or abnormal. But there is a movement in IVF now that chasing every embryo to transfer. Clinics are moving from ignorance, as we've been since I started in 1982, to transferring embryos that we know are not euploid, but will deliver a normal child. But one of the arguments scientists are making is, are these embryos truly mosaic? So I'm going to show you one of my final comment slides, which I always have at the end of my talks. Just 1 or 2 slides of my view on the topic. I'm going to show it at the start so you know where I'm going with this video, and I'll come back to this slide in about 15 minutes. So you're trying to go for a cup of coffee, have a quick snooze, go the loop. So we now have the situation where clinics who in the past have elected not to transfer mosaic embryos are now being recommended to transfer mosaic embryos on the basis they appear to generate normal babies. Appear is the operative word. But this idea only really applies to low-level mosaicism, where there's like one area. They have some cells, maybe 10 or 15% of cells, which have 1 or 2 small numbers of errors. And it's not like high levels where more than half of these cells in embryo are abnormal. It doesn't apply to high-level mosaics. Some suggest that we should not call them mosaics, just pretend they're euploid, because that means there will be more embryos to transfer, and maybe the diagnosis of them being mosaic was a bit too generous and they're really actually okay. So that's a clinical way of justifying putting these embryos back. But because mosaic embryos occur after fertilization and appear to be the result of a chromosomal weakness, that is, some embryos are more likely to have mosaics than others, then one way of looking at this is they start out as healthy, but they just have lost their way to varying degrees. And we'll relate to that. Moreover, the pathway that cells make in an embryo when they develop either into a baby or placenta, this pathway makes a decision late on day 3, and therefore many embryos become mosaic after the cell lineage has been defined, and so it's never going to really affect the baby. It was only ever the placenta. But there is also an argument that people are increasingly relying on other data is for experimental and uniform concept of embryonic repair, where evidence suggests that in the inner cell mass and later the epiblast that forms the baby, euploid cells, that healthy cells, dominate, and aneuploid cells, the unhealthy ones in chromosome abnormal, just left behind, excluded, or actively removed. But one of the concerns I have is that the term euploid is now being contaminated with maybe some low-level mosaic embryos, and if some authors have their way, all mosaic embryos will be called euploid, thereby diluting what was a benchmark pool of embryos. So we're going to start having the real problem we're going to have here is that embryos which have some degree of abnormal cells will just be bundled into, oh no, they're okay, they're all healthy, but they have a slightly lower pregnancy rate. So we're diluting what has up until been now a fairly uniform set of healthy embryos. So the first one I wanted to go to was the paper published in 2021, where these authors looked at the instance of what happens when you put back mosaic embryos. So this is from their paper. They're saying chromosomal imbalance, which is aneuploidy, is the major cause of pregnancy loss and congenital disorders in humans. Actually, it accounts for around about half. So if you look at PGT-A, miscarriage rate falls from about 20% to 10%, 20 to 12%, something like that. About half the pregnancies are lost, and the other half fail for other reasons. Analysis of small biopsies from human embryos suggests that aneuploidy commonly originates during early divisions, resulting in mosaicism. However, the development potential of mosaic embryos remains unclear. So this is in 2021. When mosaicism impacts fewer than 50% of the cells in one biopsy, what they call low to medium mosaicism, only 1% of aneuploidies are affected other parts of the embryo. A double-blind, prospective, non-selective trial showed equivalent live birth rates and miscarriage rates across 484 euploid, 284 low-grade mosaics, and 131 medium-grade. So it's not a lot of cases. And here is a nice little graphic from them. And in that study, the euploid rate was about 23%. Most of the mosaics were low-level. Smaller number of medium, and very few are high level, less than about 1%. And in their study, almost 60% of embryos were abnormal. This is, I think, where we need to be focusing our attention. So the authors write, no instance of mosaicism or uropental dysautomy were detected in the ensuing pregnancies or newborns, and obstetrical and neonatal outcomes were similar between the study groups. Thus, low to medium mosaicism in the trophectoderm mostly arises after the trophectoderm and inner cell mass differentiation, and such embryos have equivalent developmental potential as fully euploid ones. But they go on to say, although it remains unclear whether aneuploid cells arrest, become senescent or apoptotic, they are precursors of placental mosaicism. Their data does suggest the existence of early developmental bottleneck events able to normalize the mosaicism, initiating post-zygotic aneuploidies in human embryos. That's a mouthful, isn't it? As shown here, low and medium grade mosaic embryos have similar reproductive potential as uniformly euploid embryos, and according to our modelling, deselecting, that is not transferring, deselecting is a clinical term for discarding them from clinical treatment, would have resulted in a reduction of live birth rates of up to 36% in IVF PGT-A cycles. Considering that in the USA alone, more than 50,000 PGA cycles are performed every year, 50,000, right? The inclusion of putative mosaic embryos in transfer selection would rescue a remarkable number of embryos and live births. That is, they're basically saying, if you put back mosaic embryos, we're going to get a lot more babies. Or in other words, by not transferring, we're throwing out a lot of potential babies, and therein lies the potential for litigation somewhere down the track. Someone is going to sue a clinic based on this approach. Just briefly about counselling. This is not an open access article, and therefore there's not a lot of information. You only gain it from the abstract, but in this study of 1,000 odd cycles, only 8% of people had made a decision on the transfer, the fate of their embryos. That is, only 8% decided to have the embryos, made a decision. The rest just decided they didn't want to know about it. And 23 of these 99 patients that decided to make it, 23 of the 99 cycles where patients made a decision, only 23% or only a quarter of them actually decided to transfer. So most people didn't make a decision on it, and those that did decided not to transfer. In most cases, patients underwent genetic counselling before the decision. 20% didn't have any genetic counselling. It was all done by the clinician. I'm sure they're quite competent, but I think that they have their own vested interests. And there's been no further publication on the role of genetic counselling in patient decisions about what to do with mosaic embryos. And I think that is interesting itself. That is, to a large extent, clinicians are not allowing patients the opportunity to have genetic counselling when they're having PGT-A. 50,000 cycles a year, there are not enough genetic counsellors. So there's two views here. About 20% of tested embryos were mosaic. 50% were low, or maybe 60% were low, and 50% were medium to high. Originally, these weren't transferred, but now increasingly some are being transferred. It seems there is a difference in the likelihood of healthy children when low-level mosaics are transferred. High-level mosaics appear to have less likely to proceed to healthy live births and significantly lower pregnancy rates. There are significant concerns about the ability of the laboratories to do the diagnosis, and clinicians are increasingly using the concept that embryos may be able to self-correct in the cell layer that gives rise to the fetus. Okay. So basically today, I think I've already done that bit, but what I want to say was, they concluded that neither the reproductive history or the information on mosaic embryos characteristics through counselling seem to be determinative for patients when deciding to transfer mosaic embryos. So promising and increasingly data on clinical outcomes, which is the only thing they're really interested in after mosaic embryo transfers, will be of utmost importance to soften the risk perceptions regarding mosaic embryos and to give a better simplified and more evidence-based counselling. So when I think people talk to clients about they have a mosaic embryo, they say some cells are abnormal, all they hear is abnormal and they don't want the embryo transferred. But the role of counselling may be to give them more nuanced appreciation of all the data, and they can always go back and look at my first video if they really wanted to. I'd like to move on now to the ability of laboratories to diagnose mosaicism. This one came from a group of Italian, these I think are American authors. So the study question was, does the diagnosis of mosaicism affect ploidy rates across different providers offering pre-implantation genetic testing for aneuploidy? So in other words, do all providers give the same diagnosis? And if not, how does it affect the reporting of clinics to their clients? And the answer is, their analysis of 36,000 blastocyst biopsies carried across 8 genetic testing laboratories revealed that euploidy rates were significantly higher in providers that reported low levels of mosaicism. And let me explain this. Once again, lots of words, but it's important. We show that, this is the authors, we show that the proportion of patients with only mosaic embryos available for transfer vary considerably amongst providers ranging from 1 to 11%. With only mosaic embryos for transfer. While we cannot, that's because a lot of PGT-A testing is done on older ladies where they have few embryos, and a lot are aneuploidy. So while we cannot establish with the precise number of these patients who decided not to undergo mosaic embryo transfer, we show that ultimately only about 12% of all mosaic embryos are transferred. So there's about 1 to 10% of potential transfers only involve mosaic embryos. So there's no euploid embryos for transfer, and all the rest are aneuploidy. And of those, only 1 in 8 people elect to have them transfer. So in that 7 out of 8 cases, the couples decided to discard the embryos and have another go or go off and have a holiday. Mosaic diagnoses have thus inherently complicated outcome interpretations and embryo transfer policies. Cole, which is the paper on counselling, showed that many patients do not end up using their stored mosaic embryos primarily due to a high risk perception associated with such a diagnosis. So I think in 2022, most people would have heard mosaic and said abnormal, don't want them. Increasingly in their study, neither reproductive history or information on mosaic embryo characteristics received through counselling played a significant role in the clinical decision about whether to transfer mosaic embryos. While many patients may decide to keep their mosaic embryos stored, few end up using these embryos for clinical treatment. So what you have is this disaster. We have the potentially low-level mosaic embryos, which, as I'll talk about later on, may actually end up being quite healthy, but being left in storage because people just are too scared to use them. And you know what? It's their life. And if they were having a baby, and an abnormal baby, you understand why they're concerned. However, as the authors go on to say, by limiting the availability of embryos for transfer, reporting mosaicism may reduce the chances of success in an IVF treatment with the PGT-A. Therefore, in the current landscape of diverse practice and technologies, the decision to report mosaicism must be approached cautiously. So they're basically saying here that because you're actually deciding to call an embryo a mosaic embryo mosaic, you are automatically committing it to be stored and not transferred. And in a clinical environment where the name of the game is to put as many embryos as you can, particularly in older women, then this is affecting the clinical management of these cases. This study, the author study, shines a light on the complexities of play and underscores the potential drawbacks of reporting low-level mosaicism. As the field navigates these challenges and until further clinical data are available, the authors advocate for a meticulous consideration of these insights and encourage continued efforts towards standardization to enhance embryo utilization and patient outcomes. That's a bit of a mouthful if you understand. It's almost hard to know what they're saying. They're actually saying they need more standardization amongst all clinics about what to do. And clearly they're saying the standardization should be to put them back and don't call them mosaic, call them euploid M or something. Straightforward PGA diagnosis will alleviate the current risk perceptions surrounding mosaicism and ensure that potentially viable embryos are not being discarded or left unused. And just to give you an idea, this is an open access article, it's free. So you can see here, this is the provider's A to H. So depending on what clinic you go to, who they send your biopsy material off to, this is the average number of euploid embryos tested. It's roughly about 40%, you can see here. But some laboratories only report maybe 35 and others record almost 55%. And what they're doing is, the ones that are reporting a lot of euploid embryos are underreporting mosaicism. So this case, provider A, they don't report any mosaic, so there must be some, but they're cut off. The system inside the laboratory for deciding that there's a cutoff being mosaicism, they're set so high that they're actually, by definition, referring all embryos as being euploid. And I assume that means some high-level ones, which actually will miscarry, are being included in this, captured in this group. And here's just a graph showing that the more the clinic will identify and report mosaicism, the fewer euploid embryos they have available. And by inference then, that the more they decide to report embryos as being mosaic, the fewer number of cycles with one embryo to transfer are being found. So if you're a patient, depending on what side of the bed you sit on, you hope you go to a laboratory like A or B that report most embryos as being euploid, therefore you'll certainly get it transferred, and there's a chance some of those will be high-level mosaic, but basically everyone's saying, well, they're not abnormal, therefore they're normal. And down here, your clinic may refer you to a laboratory which actively reports every mosaicism, and as a result, instead of 80% of women having an embryo transfer, it's down around about 73. So it's not a lot, but it's enough. In 50,000 cycles a year, that's a lot of cases. So this study suggests that amongst a number of testing agencies, there is no uniform reporting of mosaicism. The agencies that report low incidence of mosaic embryos appear to report more euploid, That is, they report more mosaics as euploid, and therefore the embryos are transferred. I think I'm labouring this point, but I think I need to. The agencies that report a high incidence of Mosaic embryos appear to have fewer euploid embryos. That is, they report more mosaics as mosaic, and therefore the embryos are more likely not to be transferred. The authors say, while we confirm equivalent clinical outcomes following the transfer of mosaic and euploid embryos, we found that a significant proportion of mosaic embryos are not used for IVF treatment. So one part of the puzzle is how testing agencies define and report mosaicism. The clinics send the data off, the report comes back normal or abnormal, and reporting them as mosaic, particularly varying degrees of mosaic, makes it complicated for everyone. But remember, these embryos go on to form babies, and some are healthy and some are not healthy. Some will go to live birth, some will miscarry. And how you report the embryos, I think, is the current issue within the industry. The next paper I'd like to talk to is looking at, in fact, whether it makes any difference or not. So the object of this paper was to determine whether reporting putative mosaicism based on the intermediate copy number provides a prediction of reproductive outcomes and should influence embryo selection in clinical practice. Intermediate copy number, which I'll explain in a minute, is another word for being mosaic. That is, the copy number is not equal to 2. It's more than 2 or less than 2, but it's a funny sort of number. It's not 1, it's not 2, 3, or 1. It's 2.2 or 1.8 or whatever. So what they're really saying is, does reporting mosaic embryos alter the pregnancy rate? And knowing that the transfer is more likely to result in a non-mosaic baby, should it be reported at all, since it causes stress in the clients and fewer embryos to transfer? That's the crux of the clinical question. So the object was, I've already said that once, so the conclusion the authors came to, although the presence of high-level intermediate copy number in the trophectoderm biopsy was associated with a modest reduction in live birth rates, because of its low incidence and limited effect size, mosaic reporting did not contribute to a meaningful improvement in clinical outcomes. So they're basically saying high-level mosaicism, which is relatively rare, and the one they're concerned about, really was with such low numbers you can almost forget about it. And of course, you're a client that has a high-level mosaic embryo that someone says is normal, and that's a different kettle of fish. In our clinical and laboratory settings, reporting putative mosaicism provides no clinical benefit and should not guide embryo selection in routine IVF. Now, we don't want to know about it. So what they did, they conduct a large multi-site double-blind non-selection study, including 10,000 single embryo transfers in 7,500 cycles. The findings were independently valid, so they did the transfer, they then went back and looked at the data themselves and looked at the intermediate copy numbers data, was unblinded after the data was, after transfer was, embryos were transferred. Then they looked at it to see the outcome. And I need to stop here. This is a bit about intermediate copy now. I've got to say, I'm not an embryo geneticist, right? I'm just an old geneticist. But this is what we're looking at. If I asked AI, what is intermediate copy number? And this is what, God bless them, ChatGPT or Gemini told me. Intermediate copy status is often used in pre-implantation genetic testing to identify mosaicism, is measured by detecting DNA levels that fall between the expected number of values of 2 for diploid or a full aneuploid 1 or 3. That is, it's a little bit abnormal, but not a lot. This is achieved through quantitative analysis of DNA through a biopsy trophectoderm using next generation sequence. So this is what the data looks like. A nice little graph. Each one is a different chromosome, 1 to 23 in X and Y. And if you have an aneuploid, you'll find that the blue level is up to here or down there. But here where you have intermediate numbers, you can see here, that tells you that half the chromosomes are normal and half the chromosomes are abnormal. So I have to say, when you read this paper, it's a really good paper to read, but it's challenging to understand, I have to admit. I think you do need to be a geneticist to really, or clinician, because they can understand it. It basically reviewed the outcome, the transfer of euploid and mosaic embryos, and found, if I use that spelling mistake there, were the same. In other words, reporting putative mosaicism in PGT-A offered no clinical benefit. The results provide strong evidence that within current clinical and laboratory guide, reporting putative mosaicism in PGT-A offers no clinical benefit, and mosaicism status should not therefore be influence embryo selection about whether to transfer or not. Then they go on to say, however, in the absence of any evidence of excess mosaic pregnancies after almost a decade of outcome monitoring, together with the growing body of blinded data and the results presented here indicate that the clinical practice should move away from reporting mosaicism. In other words, the embryo should be reported as euploid or aneuploid, and that's it. And so then you have to make a decision, the industry has to make a decision about which ones you call euploid, which ones you call aneuploid. This shift would avoid unnecessary patient distress and prevent the discard and deprioritization of viable embryos. Further compounding the issue of mosaicism reporting in clinical practice are inconsistencies in the intermediate copy number reporting criteria. That is, they have different cutoffs and thresholds, which have contributed to variability in aneuploid rates across PG laboratory. This variability has diverted attention from the primary objective of PGT-A, which is to identify and deselect uniformly aneuploid embryos arising from the meiotic errors that you have right at the very start in well-established biological methods and outcome. And I think that the authors got a fairly valid point there. Now, two quick papers at the end, then I can finish up. You can go and have another cup of coffee. A paper from China. I'm not quite sure the ethics of this. I'm not sure we would do this in Australia. But they took 20 human embryos, donated for research, I assume. Well, they would have been. And they isolated every cell in those blastocysts and showed that 25% of aneuploidy was common in all the embryos. That is one. So basically, they said they had 20 embryos, 14 out of 20 blastocysts, 70% contain chromosome complementary cells, suggesting genetic mosaicism is underestimated in routine PGT-A. That's because they're only taking a small biopsy from the trophectoderm. Additionally, the analysis on 20,000 single cells from day 8 to 14, where the embryos, they allowed the embryos to implant and outgrow in a culture dish, showed that 90% of those embryos all were mosaic. And so the embryos started to develop further in the blastocyst stage. They all started to have mosaic cells. And lastly, I'd just like to introduce you to a paper that was published about a week or 2 weeks ago. Embryonic ploidy correction, an update on mechanisms insight into mosaic embryo transfer. This, I think, is an excellent paper. It's free, and I think it's really easy to read, and I suspect it should be mandatory for all embryologists to understand a little bit about their craft. So basically, pre-implantation embryos frequently exhibit aneuploidy and chromosome mosaicism, yet emerging evidence suggests they may possess mechanisms for ploidy correction that can mitigate these abnormalities. Several potential pathways have been proposed, which they discuss in the paper, including selective apoptosis of abnormal cells, cellular exclusion of aneuploid blastomeres, compartmentalization of abnormal cells into the trophectoderm, and chromosomal rescue events, such as trisomic and monosomic rescue, while in some other embryos, no correction occurs, leading to persistence of aneuploid cell lineages. And this is just to wake you up, making you be nodding off. This is the argument they took. If they don't arrest, if they actually reallocate cells, if the cells are removed by apoptosis, or the cells are rescued, that an abnormal one is fixed using internal genetic capabilities to convert a aneuploid cell to a mosaic. And I think you just need to read the paper. In fact, I'm doing a whole video on that. So they say follow-up studies on mosaic embryo transfer outcomes indicate that some embryos can eliminate or segregate aneuploid cells, leading to successful live births. However, the extent to which self-correction occurs and the precise biological mechanism underlying these processes remain poorly understood. The likelihood of successful correction depends upon the proportion distribution of aneuploid cells, as current evidence shows that embryos with high-level mosaicism have reduced development potential. And then just lastly, one quick paper brings back to earth from Campos, Scorio, and Fleming. This was a little while ago, in 2024, so it's almost old hat now. But basically, They argued the implementation of NGS, next generation sequencing, into pre-implantation testing for aneuploidy has led to a high prevalence of mosaic diagnosis within trophectoderm samples. Regardless, mosaicism could potentially increase the rate of live birth children with chromosomal syndromes, although available data from the transfer of embryos with putative PGT-A mosaicism are scarce but reassuring. So it's an interesting, this is in 2024, obviously early in the year. So that's almost 2 years ago. It's interesting we had 2 years. This makes a lot of difference. Even with lower implantation and high miscarriage rates, they do acknowledge that mosaic embryos can develop into healthy births. Even with lower implantation and high miscarriage rates, so I mean, carrying out the text, can develop in healthy live births. Therefore, this urges an explanation for the disappearance of aneuploid cells throughout the development to provide guidance in the management of mosaicism in clinical practice. Technical overestimated mosaicism, that is the attempt to do with the diagnosis, together with some form of self-correction mechanisms during the early post-implantation stages, emerge as the potential explanations. So what are the main findings? Self-correction mechanism with preferential apoptosis in the inner cell mass lineage and in aneuploid, euploid mosaicism emerges as a potential mechanism to eliminate aneuploid cells during embryo development. Assumptions of mosaicism from intermediate copy number in embryos PGT-A are inaccurate, and identifying often mosaic embryos that are in fact are uniformly mosaic or aneuploidy. So part of the real problem has been that genetics has got ahead of our skill in understanding what's going on, and embryos are being incorrectly allocated to being abnormal. And I think that this is a huge litigation that needs to be addressed very quickly. So what's the implication of the main findings? The embryo plasticity represents a promising model of normalization to euploid embryo constitution, but may become mandatory to redesign the current technologies to explore novel methods to improve the accuracy of mosaic definitions. Okay, finally, my comments. We're almost there, guys. One should always know the answer to the question before it's being asked. The initial drive for PGT-A was to separate euploid from the aneuploid embryos, thereby reducing the rate of miscarriages and shortening the time to pregnancy by only transferring viable embryos. What we have is a situation where about 20% of embryos are between good and bad. The problem is that low-level mosaic embryos behave like euploid and high-level mosaic embryos behave like aneuploid embryos. Clients are being asked to make a decision about transferring embryos that have been identified as not normal but okay, or we hope will be okay. And I think one of the problems is, people are asking the question, is that maybe this identification is actually the problem. Notwithstanding significant variations in how mosaic embryos are reported, there appears to be differences in how fertility societies recommend their management, but that I think will be updated with future issues. The real problem is that the material being used to make the diagnosis is the trophectoderm and not the inner cell mass. It's a bit like looking at a car to see how good the driver is. It's just using the wrong material to make a decision about babies. And even though we've known that for the last 20 years, I think all the problems are now coming home to roost with dealing with mosaic embryos. So you've seen this slide before. So hopefully it's all in context now. So now we have the situation where clinics who in the past elected not to transfer mosaic embryos are now being recommended to transfer mosaic embryos on the basis they appear to generate normal babies. There's only place of low-level mosaic embryos and not the high level, so they're splitting. Less than 50%, they're okay. More than 50%, no, they're no good. You can see the problem here that there's just got to do with definition. But there's a lot of embryos not being transferred that could give rise to healthy babies. But there's a risk. These clients, they're the ones carrying the risk, not the clinics. Some suggest that we should not call them mosaics, just pretend they're euploid because there are more embryos to transfer. So this is a clinical way of saying you're throwing embryos out, don't want to use them, but we'll counsel women about the risks. Because mosaic errors occur after fertilization and appear to be a result of a chromosomal weakness, the one way of looking at that is they start out as euploid, they just lost their way. Moreover, the pathway when cells in the embryo become allocated to a baby or placenta occurs round about on day 3, although there will be some videos coming up arguing differently on that. And therefore, many embryos are becoming mosaic after the baby-making cells have been selected and put aside. That's the inner cell mass. Also, as I've said before, the argument is increasingly going to be used and relied upon by clinicians of a newly formed concept of embryonic repair, where evidence suggests that in the epiblast, the little part of the embryo after it's implanted that will give rise to the baby, the euploid cells dominate that, and all the aneuploid cells, the normal ones, are left behind, excluded or removed. But I still like to come back to say, at the moment, one of the worst things that could happen is if we start calling all mosaic embryos euploid, is that we'll start to reduce the efficiency of a lot of publications that are only looking at euploid embryo transfers. And just to throw a spanner in the works, I wasn't going to include this slide, but when in speaking to Anna, I think I will, just to throw a spanner in the works. The authors here also comment on cases where embryos initially diagnosed as aneuploid, that is, right at the very start, there's an error in the meiosis when the embryo is first corrected. And then there is a process whereby the embryo is able to repair or rescue these. I'm not a great fan of this, but I think something that we have to consider, and maybe a future video. But the authors state, however, an alternative and not mutually exclusive scenario is that some embryos may reach from aneuploid conceptions, but subsequently undergo partial or complete ploidy correction. This could occur through mechanisms such as anaphase lag, selective loss of abnormal chromosomes, or elimination of abnormal cells, resulting in a predominantly euploid lineage. In such cases, what we label as mosaic may actually represent a rescued embryo rather than one that has simply accumulated errors. Okay, so my final comment. I bet you're all hanging out for a glass of wine. So are mosaic embryos euploid or aneuploid? Now, I'm not an embryo geneticist. I'm not a clinician. I'm not a geneticist. I'm looking at these embryos from the point of view of embryology and clients. So my answer is I think they're a bit of both. Clients need to be aware of this before they agree to PGT-A, because one of the issues they will face will be the difficult decision about whether they should keep or discard any mosaic embryos they may have, or whether they should transfer it. And if they transfer it, will it be okay? And I think I have to say, looking at all the papers I've read, I think you would do with a reasonably high degree of confidence that you will have a healthy baby. So I've read about 30, 40 papers on this now, and my sense is that low-level mosaic embryos are a reasonable risk to consider, as long as you understand that what's happening is actually fairly normal. But I like to point out that I'm an old school embryologist. I've been doing IVF since started my PhD in 78, been doing IVF since 82, put back thousands of embryos and made thousands of babies. Sometimes ignorance is bliss. Finally, after 40 years, all good morphology and some not so good embryos have been transferred, regardless of their euploid status. We just didn't know any of this. And granted, the miscarriage rate was higher than with euploid embryos, and I accept that, but no different to what was ever in the background miscarriage rate. But despite these extensive studies, they've always shown we've generated healthy children. So I actually think that this is a bit of a storm in the teacup. And I think that maybe the authors who want to do away with mosaicism should be encouraged to pursue their case, because I think that at the end of the day, they've created a problem which will never be resolved. However, if they don't address it, and you have a situation where clinics are not putting back embryos that could give rise to children, or they put back embryos which could have been mosaic and have some sort of pregnancy complications. I'm sure some people will find out. There will be people that will sue. If you look at the issue with Monash IVF, but they tried to do the PGT-A using non-invasive, 2 people complained about that, and the impact was huge. And I can see that the same thing, even worse, will be how you deal with mosaic embryos. So I'd like to stop now. I think I need a glass of wine. My name's James Danger. I'm an embryologist from 50 years experience. The videos on my channel here are an attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your staff. I am not a medical person, and this information is not medical advice, but hopefully it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what you're doing, press subscribe. You may like to support me in my GoFund page. I'm still trying to get my Patreon program up and running, but whatever you do, please leave a comment and press like. I'd like to recognise that this is being funded by my other activity, which is an online EQA program for training embryologists. And you can see all the different things you can do there. Just go to ferdaid.com. And lastly, I'd like to thank you for your perseverance. If you've got to this point, I'm impressed. I do understand that IVF is a personal journey that involves the actions of many staff, many techniques and many concepts, and it helps to understand all aspects of that journey. I hope this information be of value. If you like the information provided, please tell other IVF clients about this service and please subscribe. And that, my friend, is enough for me. I'll say goodbye.